My pleasure to be with you tonight to speak about an important subject, which is male oncofertility. We all know that cancer and cancer treatments have an adverse effect upon men's ability to father children. It impairs spermatogenesis by hormonal derangements as well as by direct involvement of testicular tissue and the reproductive tract. Indeed, radiation affects directly the hypothalamus in the pituitary, leading to low FSH and LH, and exerts also a direct effect on the testis. The same with chemotherapy, direct effect on the testis, attacking sperm DNA, then spermatocytes, then spermatogonia, then Sertoli cells, and finally Leydig cells are the least to be affected by such insult. Additionally, erectile and ejaculatory dysfunction may result from debilitating physical and emotional impacts of the disease and as a side effect of various medical and surgical therapies. So surgery can be a bilateral orchidectomy or prostatectomy or retrocranial lymph node dissection, and it will remove organs necessary for reproduction or disrupt the nerve supply. So chemotherapy and radiotherapy cure cancer by destroying rapidly dividing cells, and spermatogenic cells are also rapidly dividing cells and are very vulnerable to chemotherapy and radiotherapy. Despite the use of gonadal shielding with radiation therapy, and despite efforts to tailor chemotherapy to be less gonadotoxic, nearly all cancer treatments, while life-saving, will negatively affect and impact male infertility. So statistically, most of men of reproductive age with cancer will survive, and the ability to father children following treatment is a very important quality of life concern of them. Even though many men will recover spermatogenesis following cancer, unfortunately, will not recover. And it's very difficult to predict who will and who will not recover after the treatment, because many variables, including type of cancer, extent of disease, doses of chemo or radiotherapy, and susceptibility is quite different in these patients. Additionally, once spermatogenesis returns to normal, it does not rebound to the same level prior to treatment, and sperm quality after treatment is often a concern. It was suggested that generous analogs and antagonists can be used to minimize germ cell and preserve spermatogenesis. Actually, it's an experimental issue, and some promising data have been reported, but it's not a practical one to be advised. The most practical is cryopreservation, which is a standard preservation method before chemotherapy. However, it remains underused, and it can be done for any candidate, adult men or boys producing sperm in the ejaculated and cryopreserved. Indeed, the advances in assisted reproduction can help us in even after long-term storage of poor quality sperm, can help these patients to have their own children. And high fertilization and pregnancy can result even with severely impaired semen parameters. So it's very worthwhile cryopreserving any live sperm that you can find in these patients. All male requiring chemo or radiotherapy, including adolescents, should be offered the possibility of storage. This is a very, very important preventing pre-therapeutic capability to preserve the progeny after that. And you have to know that semen must be collected before the therapy starts, because if the therapy starts, there is a risk of mutagenesis in spermatozoa. And also it has a significant psychological value because it gives the patient the hope of future paternity. So counseling is very important for these patients, and it should be done before and during and after treatment. And it's very challenging because patients are trying to come to terms with a cancer diagnosis. They have constitutional symptoms of their disease. They are tired. They cannot do an informed decision, and for them providing semen is difficult. And usually cancer treatment often needs to be initiated very soon, sometimes within hours. Also, the patient is not sure how long the sperm can be cryopreserved. Actually, we need to assure patients that there is a report reporting that the patient was using his sperm after 21 years. And I believe it can stay longer than it. Why not? It's already frozen. So it's advisable to tell the patient not to discard sperm until they are certain that they have returned to normal fertility and have completed their family. You need to ask the patient that after treatment he has to use a contraception because there is a risk from chromosomal structural damage that can happen to the sperm, and contraception is very important. Ideally, 2 to 3 ejaculate samples should be obtained, and this is largely enough to have adequate number of sperm for cryopreservation, and sometimes even one sample is enough because you are going to divide it in many smaller samples. And you know, it's, as I told you, it's difficult for these patients, so sometimes they are unable to masturbate, especially teenagers. So you have to be very gentle in counseling and make the environment very comfortable to collect the semen. And actually, ejaculation is difficult because these patients are anxious, are fatigued, are hypogonadal, have pain, have sometimes diabetes or some neurological problems, or suffering from drug side effect like opium and painkillers. Sometimes we are using this type of machine, electroejaculation, so that we can help them to ejaculate. And sometimes we are obliged to do testicular sperm extraction. Regarding poor semen sample, and we have a nice talk with Dr. van der Zalmen. These patients, many of them have already poor semen sample before starting any treatment. And because the cancer can affect the hypothalamus and the pituitary gonadal axis, and may also injure the germinal epithelium to cytotoxic immune response to cancer or fever or malnutrition. So you can find a variety of severely abnormal semen analysis such as azoospermia, necrozoospermia, oligozoospermia, or cryptozoospermia. And this markedly abnormal semen may jeopardize fertility preservation. So you need to repeat semen frequently in order to get a good sample to preserve. And you are obliged in such cases to do more than one ejaculate. And if you cannot freeze in a sample, you will need to do a surgical extraction. Even in men with a testis cancer, even if he has a solitary testis. So if you have live sperm, it's okay. If you don't have, you need to obtain sperm from the testicles. If the patient is not providing any ejaculate, you have to see if he has a retrograde ejaculation and take sperm from urine. If he is unable to ejaculate, so you need to do vibration or electroejaculation. And if not, you have to go to surgical extraction. After that, you need to advise the patient that if he has radiotherapy, he has to shield his testis to protect it. Sometimes we see patients with testicular cancer, and you need to offer all these patients sperm cryopreservation before going to orchidectomy. And this is very important because even he has a solitary testis with sperm, he may turn to have azoospermic after removing the testis with cancer. This has happened in 9% of men who have a normal contralateral testis. And you need to obtain ejaculated specimen before orchidectomy. If not possible, you need to retrieve sperm from the testis at the time of surgery, as this may be the last opportunity for the patient to father a child. So some of them will be azoospermic, some of them will be severely impaired. So you need immediately after orchidectomy to take the testis on a sterile backbench. And in these testes, you need to find the healthy tissue from which you are going to do a TESI, and it's called OncofertilityImportant. And you will find some sperms that you are going to cryopreserve and save the future of the fertility of this man. Regarding children and adolescents, these are very special group and must be approached thoughtfully. Sometimes they have undergone puberty with initiation of sperm production, and as adults they can be affected. Unfortunately, there is no available fertility preservation program at pediatric healthcare facilities, and the knowledge of vulnerability of these individuals to cancer therapy is not that much known, and doctors doesn't know what to tell to such kids and small adults about this issue. So this is very particular, and this group, it's very possible that we can help them, and it has a sensitive approach, and we need a variety of level of physical and psychological help. So puberty is often heralded by nocturnal emission, but sometimes the patient is not sure if he cannot tell you if he has such emission or not. So you take a sample of urine, and if you find sperm, you know that he can have a sperm, and you can try to have a semen by masturbation, or sometimes by electroejaculation, and lastly by intervention. In prepubertal boys, they don't have sperm, so many investigators are studying the process of germinal epithelial stem cell isolation and cryopreservation. Since 2007, the ultimate goal will be transplantation of this tissue back into the patient after completion of cancer therapy with resumption of spermatogenesis. However, this is purely investigational, and until now, nobody succeeded to have a mature sperm from this type of experimentation, hoping that in the future it will be possible to have sperm from these frozen samples. So this was successful in animal model by xenografting, but not in human till today. The process of sperm freezing are easy. Just you put in cryoprotectants and you go to your freezing machine or in vapor, as Dr. Van der Zullen showed us, and you can use it in IVF or ICSI better than IUI. So to conclude, I need to tell you that cryopreservation is a preventive therapeutic option for oncological patients and offers the chance to maintain the potential parenthood. At the present time, ejaculated or testicular sperm remains the principal established modalities of fertility preservation. Patients need prompt counseling, and they need to know their options for fertility preservation, and they need rapid referral to the appropriate program. And fertility preservation program should offer patients rapid access to an interdisciplinary medical team, including reproductive surgeons, in an experienced ART program that can offer a full complement of fertility preservation technique on short notice. And surgical sperm retrieval requires a reproductive surgeon who is knowledgeable in these techniques, in combination with an andrology lab that is willing and available to work with the patient and the surgeon to coordinate this important service on very, very short notice. Thank you very much.